I'm Jamie, and we are going to talk about Methicillin Resistant Staph aureus. This is an organism that is actually responsible for several difficult to treat kind of human infections, and it is also known as multi-drug resistant Staph aureus or oxacillin resistant Staph aureus. The outline of this lecture is to give you an overview of the brief outlook of the microbiological as well as molecular characteristics of the organism. And we will go through common infections encountered including MRSA bacteremia, infective endocarditis, bone and joint infections, skin and soft tissue infections. Then we will discuss the treatment of this illness with focus on the anti-MRSA antibiotics available. And lastly, we will discuss the mechanisms of Vancomycin intermediate resistance Staph aureus, also known as VISA, and the much feared Vancomycin resistant Staph aureus, VRSA. Staph aureus are gram-positive cocci formed in clusters, and they look like clusters of purplish dots on a gram stain, forming bundles of grapes. The colonies have a yellowish color, and in the lab, rabbit plasma is added, and Staph aureus will coagulate rabbit plasma. This helps to differentiate it from coagulase-negative staph. Methicillin is a narrow-spectrum antibiotic and previously was used to treat infections due to Staph aureus, particularly Staph aureus that produces beta-lactamase. This is currently replaced by the better-known cloxacillin. However, in the lab, methicillin still has its use, and it is used to determine the antimicrobial susceptibility of Staph aureus to beta-lactamase-resistant penicillins. Historically, MRSA is first isolated in 1961. MRSA is resistant to all penicillins and most of the known cephalosporins, with exception of a new 5th-generation cephalosporin, which we will talk about later. MRSA is not intrinsically more virulent than methicillin-sensitive Staph aureus, but it is more difficult to treat with standard antibiotics, and hence more hazardous to be infected with one. The resistance to methicillin is mediated by penicillin binding protein PBP2A, encoded by MAC-A gene, which is in turn carried on mobile Staphlococcus chromosome cassette. Most invasive MRSA infections is healthcare associated. In fact, with pulse field gel electrophoresis, most of the healthcare associated MRSA is of the strain USA 100 or 200, and this carries SCC-MAC type 2 genes. Healthcare associated MRSA is defined as MRSA infection that occurs more than 48 hours following hospitalization, or MRSA infection that occurs outside of the hospital within 12 months of exposure to healthcare. Examples of exposure to healthcare includes a history of surgery, recent hospitalization, dialysis, or residence in a long-term care facility. The risk factors for developing infections due to MRSA includes antibiotic usage, prolonged hospitalization, stay in intensive care unit, hemodialysis, skin colonization with MRSA, or proximity to others with skin colonization to MRSA. MRSA-infected patients have higher mortality and have a longer hospital stay, and hence a higher healthcare cost compared to those who were just infected with a methicillin-sensitive Staph aureus. In fact, meta-analysis shows that patients with MRSA bacteremia are at 2-fold increased risk of dying compared to those with just MSSA bacteremia. Community-acquired MRSA, CA-MRSA, is an emerging infection. Most strains are of USA 300 and some are USA 400. These carry SCC-MAC type 4 or 5 gene as well as a plasmid known as PUSA03 that confers resistance to beta-lactamase. Most will express pentovalentine leukocidin, which is a cytotoxin, and this results in leukocyte destruction as well as tissue necrosis. CA-MRSA mostly cause skin and soft tissue infections, and rarely they can cause severe infections like necrotizing fasciitis and necrotizing pneumonia. And of note, necrotizing pneumonia is usually associated after one having influenza pneumonitis, and this has particularly high mortality and reported to be up to 60%, especially in young adults. This table summarizes the differences between community versus healthcare-associated MRSA, which are already discussed. Infections due to MRSA. Resistance to methicillin does not make MRSA more virulent than MSSA, but it does make it more difficult to treat with common antibiotics available. So we shall go through some of the common MRSA infections in clinical practice. The key point to note when clinicians deal with MRSA bloodstream infections is to distinguish complicated from uncomplicated bacteremia. This has implications on the further investigations pertaining to the choice of antibiotics and the duration of treatment of the patient. These are the important points. In complicated bacteremia, the patient is likely to be from a community with no previous healthcare contact. History of fever is usually prolonged for more than 72 hours, and in fact, bacteremia is likely to be prolonged, and follow-up blood cultures usually is persistently positive. And patient may have prostatic material, for example, prostatic valves, joints, devices, or even long lines. Hence, in evaluation of a patient with MRSA bacteremia, the clinician should ask for a detailed history, examine and investigate to answer the above questions, and repeat blood cultures 2 to 4 days after initial positive cultures, as well as echocardiography are common investigations to aid in the management of the patient. So, why is it important to know if bacteremia is complicated or not? Because it predicts the risk of disseminated disease. MRSA and MSSA disseminates and results in seeding infections, and this causes high mortality and morbidity. The risk of developing endocarditis during Staph aureus bacteremia largely depends on the valve. This is definitely higher when a prostatic valve is involved. So naive valves actually carry a risk of 12%, while prostatic valves carry 40% risk. In fact, in cardiac devices, it's been known that nearly 30% of the time when there is bacteremia, the cardiac device may be seeded. And we're talking about cardiac devices of pacemakers, automated implanted defibrillators. The treatment of naive valve infective endocarditis usually involves an anti-MRSA antibiotic for a prolonged course, and combination treatment is required for prostatic valves. Seeding to bones and joints results in osteomyelitis and septic arthritis, with about a 3% reported incidence. Most patients with osteomyelitis presents with pain. However, neurological deficits usually occurs late, and hence delaying the presentation of the patient. About 6% of Staph aureus bacteremia develop septic arthritis, compared to an even higher incidence in patients with prostatic joints. And most patients present with pain again. The knee is the frequently involved joint, and the joint aspirates with gram stain may identify up to 50% of the patients. Treatment frequently requires antibiotics as well as arthrotomy and washout of the joints. And in the setting of a prosthetic joint, this frequently requires removal of the implants in a 1 to 2 stage replacement. Skin and soft tissue infections. Small abscesses can be easily treated with incision and drainage alone. However, larger abscesses may require systemic antibiotics, in addition to drainage. The choice of antibiotics depends on whether the strain is community-acquired or hospital-acquired MRSA. Community-acquired MRSA may be susceptible to other kind of oral antibiotics, for example, Bactrim and clindamycin. The healthcare-associated MRSA treatment is usually with vancomycin, although there are other kind of antibiotics available, for example, tigecycline, daptomycin, and linezolid. Hematogenous seeding may result in deep tissue abscesses, and areas frequently encountered include the spleen, liver, kidneys, brain, lungs, and the psoas muscles. The patient presents with symptoms related to the site of involvement. For example, in psoas abscess patients, they usually present with pain in the hips, and seizures in patients with brain abscesses, and chest X-ray lung nodules in patients with lung abscesses. The management includes appropriate investigations, which may include blood cultures, imaging, and then aspiration of the abscesses, or even surgical drainage, and antibiotics. The antibiotic choices usually is vancomycin or the other new antibiotics. In general, the principles of treatment of complicated Staph aureus bacteremia is a combination of surgery and antibiotics, and sometimes even prolonged treatment may be required. So when you are faced with a patient with persistent fever, despite treatment, think of seeding infections. This table illustrates the resistant pattern in Staph aureus. The definition of resistant depends on the minimal inhibitory concentration MIC to vancomycin. MRSA MIC to vancomycin is less than 2 micrograms per ml, and as previously discussed, the resistance is carried by MAC-A gene that codes for penicillin binding protein 2A. In VISA, MIC to vancomycin is usually in the range of 4 to 8, and this is due to an unknown mechanism that results in a thickened cell wall. And in VERSA, the MIC vancomycin is more than 16, and this is due to Van-A gene that was transferred from Enterococcus faecalis, and this results in a change in the cell wall that confers the resistance. The following 3 slides has tables to illustrate the newer anti-MRSA antibiotics available. Glycopeptides, with vancomycin being the most commonly used agent in this class. And vancomycin is currently still the mainstay of treatment for MRSA infections. The common problems of vancomycin definitely includes renal as well as ototoxicity. And there are other glycopeptides available, for example, teclopanin. Telavancin is a lipoglycopeptide, and it has the problems of teratogenicity and renal toxicity. Daptomycin is the other commonly encountered antibiotic that we use against anti-MRSA effects. It is a cyclic lipopeptide. It is bactericidal and active against MRSA, VERSA, VRE, which is vancomycin-resistant Enterococcus. It is FDA approved for complicated skin and soft tissue infections, and higher doses were required for right-sided infective endocarditis. The main problems of daptomycin includes rhabdomyolysis, and because it is inactivated by surfactant in the lungs, it is not used in lung infections. Rarely, it may cause a eosinophilic pneumonia. Linezolid is the other agent that you will commonly see in clinical practice. It is bacteriostatic, and it is the only one anti-MRSA antibiotic that is available orally. It has both IV as well as oral forms, and is approved for skin and soft tissue infection. It is good for pneumonia, and it has activity against VRSA, VRE, MRSA. The main problem is the concern that it is a bacteriostatic agent, and hence it is sometimes used in bacteremia only. The main issue with linezolid in clinical practice would probably be myelosuppression, especially of thrombocytopenia, and this usually occurs after about 2 weeks use. Caution must be exercised in patients with depression and on serotonin receptor inhibitors, as you can get serotonin syndrome when used in combination with linezolid. Tigecycline is another bacteriostatic agent that is active against MRSA, VRE, and VRSA. It is used for skin and soft tissue infections, intra-abdominal infections. However, the main problem with tigecycline would probably be the problems of reaching blood concentrations of an antibiotic. It is unable to reach so, and hence it is not used for bacteremia. And patients usually complain of severe nausea and vomiting in the use of tigecycline. Quinopristine, deflopristine is used for VRE infections, soft tissue infections, as well as bone and joint infections. However, this medication needs a central line to administer. It causes hyperbilirubinemia and severe arthralgias, and hence not a preferred drug in a lot of the patients. And lastly, this is the first MRSA active cyclosporin. It's a 5th generation cyclosporin, and it is used against MRSA as well as activity against VISA. It is currently not available in Singapore yet. So in general, principles of treatment include an anti-MRSA antibiotic, and antibiotics were already discussed in the previous slides. The important thing is to destroy the source. The source of the infection could be foreign bodies and long lines. So if you can't, remove the foreign bodies and long lines. Be vigilant. Check the plug sites. Ask for joint pains from the patient. Listen for murmurs, and look for septic spots. In summary, MRSA is the common cause of nosocomial infection. Patients present with symptoms that were related to the site of infection. MRSA likes to disseminate and can cause seeding of infection. In the blood cultures, MRSA is never uncontaminant. It should be treated with respect. And the main issue in bacteremia is to determine whether this is complicated or uncomplicated bacteremia. Source control is important. The treatment of MRSA is currently still vancomycin, although this has currently been changed.